And this is a work done within the auspices of a European project called HTX that aims to provide the next generation health technology assessment framework. And we have been working together with Ehud Steinberg, Andrew Vickers, Andrea Marca, and Fabio Pellegrini to produce what I'm about to present you. I assume most of you, probably all of you, are familiar with network meta-analysis methods. Network meta-analysis is used to estimate relative treatment effects between more than two competing treatments. And the work I will present you has been inspired by a data set we had from the field of relapsing-remitting multiple sclerosis. You see on the right-hand side a network with 3 active treatments: glatiramer acetate, natalizumab, and dimethyl fumarate, that can be compared either between them in the study called Confirmed or with placebo in the study called Define and Affirm. The outcome we will be looking at is a relapse at 2 years. And we have, as you see, 3 randomized trials and data on nearly 3,000 observations from patients. And if we do a simple network meta-analysis, we will get the odds ratios that you see on the lower triangle. Less than 1 means that the treatment is effective in reducing the risk of relapse, and on average natalizumab is associated with the least odds of relapse. On the upper triangle, I have put for comparison the direct estimates from the data directly comparing pairs of treatments. But these are the estimates one will get for the effect of treatments if one assumes that all patients will benefit the same from each one of the involved treatments. But as we move towards personalized medicine, we know and we would like the treatment choices to account for patient characteristics, and it's common ground nowadays in neurology that not all patients have the same response to the same treatment. Sometimes we suspect which variables control these heterogeneous treatment effects, but in many fields this is still a question to investigate. So the focus now will be to look at these heterogeneous treatment effects and identify those characteristics that might make one patient benefit from a treatment more than another patient. Here is a patient A, and on the left you see various characteristics that we suspect are associated with differential response to the 3 active treatments. This is a patient 42 years old with a rather low baseline EDSS. This is a scale of disability. The year since the onset of symptoms, number of relapses in the last years, and various other clinical variables. And the predicted probability to relapse in 2 years is 25% with dimethyl fumarate, 28% with glatiramer acetate, and 27% with natalizumab. So dimethyl fumarate decreases the probability the most and might be recommended for this patient, whereas patient B that has higher EDSS at baseline will benefit mostly by taking natalizumab. And so at the population level as well as personal level, recommendations should be specific to subgroups, and also cost effectiveness will depend on the distribution of these effect modifiers like age, EDSS at baseline in the population we want to make inferences about. And the main tool that we will be using is, of course, network meta-regression with individual participant data to account for patient-level covariates. And many features of the prognostic models are very difficult to implement in the network meta-regression setting. Most network meta-regressions are fitted within a Bayesian framework, and then accounting for missing patient-level covariates, for example, or using shrinkage is possible, but not many methods exist, particularly for shrinkage. And so we will take another route that I will show you now. So we have 3 active treatments and placebo, and each one has a different effect on different patients depending on their characteristics, and that's what we call heterogeneous treatment effects. And we can estimate these heterogeneous treatment effects by including in the model prognostic factors and effect modifiers, and build a prediction model using individual participant data network meta-regression with a lot of covariates. But as I said, this has some problems, computational, but also practical problems. And this is why we will not do that, but we will develop a single covariate that we will call risk score or baseline risk score by developing a prognostic model of baseline prognostic factors defined here as PF. And then this risk score will be used in an individual patient data network meta-regression using just this covariate and nothing else. So I will be talking about stage 1, which is the development of this prognostic model to estimate the baseline risk score or the baseline risk shortly. And then stage 2 is the use of that variable developed in stage 1 as a covariate in an IPD network meta-regression model. And we will take advantage of the fact that prognostic research has a lot of established methodology, and we will follow standard guidance. And we will use this, what I presented you in stage 1 and stage 2 is known as risk modeling, as opposed to effect modeling, where the treatment effect variability is modeled as a function of outcome risk, and the outcome risk in the first stage is modeled as a function of covariates, and it has a couple of advantages, like reducing the risk of overfitting, because the treatment effect heterogeneity is modeled only with a single covariate, the risk score, but it assumes that the heterogeneous treatment effects are proportional to the main effect of the covariates vector. And you can find more details in this article that I cite below by Hoogland. So let's look now first at the first stage, how we developed it in the context of multiple sclerosis treatments. First of all, the kind of data we used to develop it comes from the randomized trials that we have, and we developed the model using both arms, not just the placebo arms, although it seems counterintuitive. We will use all data from all patients blinded to the treatment. The justification is described in these 2 papers where Burke et al. They did simulation studies, and they showed that you can bias the predictions if you use just the placebo arms, and this is why when you are using the risk modeling approach, the path statement for how to develop a prognostic model explicitly says that both placebo and active arms should be used at this first stage. And to develop the model, we use 2 approaches. One is we throw in the model all variables that we had, and the clinicians suggest that it is reasonable to assume that they can predict the relapse. And then we used lasso for shrinkage of the coefficients and model selection. And as an alternative, we use the pre-specified model, where we only enter the model 14 prognostic factors that were previously identified in a prognostic model by Pellegrini and colleagues. They had as outcome the annualized relapse rate, but we thought that the same 14 prognostic factors is reasonable, that they are also predicting the relapse rate at 2 years. And we use penalized maximum likelihood estimation for shrinking the coefficients. And you see on the larger circle all the names of the variables that we included in the Lasso model. In the most narrow inner circle, you see or ellipse rather, you see those that were selected by Lasso. And these purple ellipse are the prognostic factors that we used in the pre-specified model. And you see here the distribution of the people with relapse. These are the yellow areas, and the people without relapse in blue, along the risk score estimated as prognostic factor. And up we see the two distributions for the Lasso model and the pre-specified model below, and we see that the discrimination is quite low. The two distributions overlap quite a lot, and the discrimination is on average 62% for both cases after adjusting for optimism. That's not impressive, of course, but we don't really want to accurately predict at this stage the risk to relapse in 2 years. We only want to summarize all the prediction, all the predictors, possible predictors, age, sex, EDSS, and so on, in a single variable. And other models that have been using the same approach, they have also claimed that even a low discrimination could lead into a good prognostic factors for the prognostic ability for the risk score, but we will see that. So, okay, let's say we have developed this risk score by summarizing all the variables, and then we will enter it to the model, the network meta-regression model, and that is the parameterization of the probability to relapse in 2 years for individual I in study J under treatment K. And this is for the baseline arm, and this is for the active arm. Of interest are the parameters D capital, which is the treatment effect for treatment K versus placebo. And because we had very few studies, we used only fixed effects, unfortunately. And this term here measures the impact of the baseline risk as a prognostic factor, and we centralize it at the mean value of the logit risk. And this part here is the interaction between baseline risk and treatment effect. So the coefficient G is it measures how important is baseline risk in modifying the treatment effect, and it is treatment specific also. So when we fit the model in our data, we can estimate the odds ratio of each drug, each of the 3 drugs versus placebo at the study mean logit risk. And you see natalizumab is considerably better than the other 2 options. And on the next column, you see the odds ratio for a drug versus placebo for 1 unit of increase in the logit risk. So that's the exponent of the coefficient of the effect of the baseline risk as effect modifier. And for beta, which is the odds ratio in relapse for 1 unit of increase in logit risk in untreated or placebo patients, is 3.32. I think that would be more understandable as as result. So you see here on the horizontal axis the baseline risk score prior to the treatment, and on the vertical axis the predicted probability of relapse, and how the three different options perform for different levels of the baseline risk score. Within the two dashed red lines is the range of values for the risk score for which we do have patients. Outside this range, it is about extrapolating. So as we said, on average, and as you saw that in the odds ratios, the natalizumab is on average a preferable treatment because the risk of relapsing in 2 years is 46%, and the other two have larger probabilities. But that depends quite a lot on the baseline risk score. So if we take people with less than 30% baseline risk, then natalizumab and glatiramer acetate have pretty much the same average risk of relapsing. And that is quite important because natalizumab is associated with serious, rare but very serious side effects, whereas dimethyl fumarate is glatiramer acetate is an old and very well-studied drug with very few risks to take, and it's also oral. And it looks like natalizumab is more beneficial for people who have a higher baseline risk for relapsing, like people with more than 50%, and then you see the benefit with natalizumab is visible. And these results reflect also the intuition and the understanding of clinicians, and some results from individual trials where natalizumab is actually used in patients with more aggressive disease and more rapid progression. So you can find these results implemented in an R-Shiny app. Maybe I could show that to you later once we finish, if we have time. So, and the details can be found in a Statistics in Medicine paper published last year. And Konstantina has put everything up in GitHub if you want to check our model. And we are now working on extending this model, this two-stage prediction model, on two levels. One is to use observational data to develop the risk prognostic model in stage 1, rather than using the same data from the RCTs that we will analyze in the network meta-analysis model. And then we try to explore how to use aggregated level data in combination with individual patient data, and whether that's possible and desirable. And that was the first part of my presentation, which talked about how we developed a prediction model using a two-stage approach, a prognostic model in the first stage, and then an individual patient data network meta-analysis at the second stage. But we, in the next step, what we did is to start thinking whether the model we are developing is clinically relevant. Because even in the case where the predictions are accurate, the implementation of the prediction model doesn't necessarily lead to better clinical decisions. And the decision curve analysis is a technique that has been introduced by Andrew Vickers and investigates whether making clinical decisions based on a model will do more harm than good. And a key concept in the decision curve analysis is the net benefit that we calculate for several alternative strategies as a function of the treatment threshold. I will elaborate on those notions in a minute. The net benefit of a treatment strategy is the health benefit it produces minus the risk that it entails and cost multiplied by an exchange rate. And this exchange rate is associated with a treatment threshold. So when we are recommending a treatment to a group of patients, net benefit is the mean change in the health outcome, like the change in relapse rate that can be attributed to the treatment, minus the proportion of people who will take that treatment and will be exposed to the side effect, inconveniences, etc. And these two parts, the improvement in health or benefit in the health outcome on the one side and the proportion of people that take the treatment, they are given an exchange rate. And the net benefit approach has been estimated for using data from a randomized trial comparing two treatments. And in this part of my presentation, I'll show you how we extended the decision curve analysis when we have several treatment options and when the data comes not from one RCT, but several RCTs connected through a network meta-analysis. So, as I said, the key concept is the net benefit for each one of the strategies that we want to compare. The strategies we want to compare is, of course, the one according to our model. We will treat the patients according to what our model says is the appropriate treatment or the best treatment for each one of the patients. But there is also the option to treat everybody with natalizumab, everybody with dimethyl fumarates, and so on, or to treat nobody. So in practice here, we have three strategies: treat everyone with one of the three active drugs. Fourth strategy is to treat nobody. And fifth strategy is to treat according to the model. In order to show you how we estimate the net benefit, I need to explain better a little bit these two notions, the treatment threshold, what it is, and how we reach a recommendation for a treatment according to the model. And here is a reference to the original paper about decision curve analysis. So a threshold, which is specific to treatment J, is a value that the patient places on a health outcome, like the relapse rate in our case. So it's the value that the patient places on a health outcome that will lead the patient to choose the treatment J after considering its safety and tolerability. And it's also used as an exchange rate, balancing harms and benefit in the decision curve analysis. We can ask the question, which is the minimum risk difference in terms of relapse that you expect from treatment J compared to placebo, so that you will be convinced to take treatment J. So if you answer 20%, so I want a drop in relapse by 20% for treatment J, that means that you are willing to treat up 5 patients to prevent 1 relapse. And as I said, for example, natalizumab is a drug that has some issues with safety, so probably most people are not willing to take it if we tell them that, look, your risk to relapse in the next 2 years will drop by 3%, given the high probability of, given the severity of the rare side effects. But if we tell them it will drop by 35%, then they might be willing to take it. So that's the threshold for the treatment. And that is used to recommend a treatment by the model. So which treatment our model recommends for each patient. So it depends on the threshold that we will place to each treatment. For a patient I, the recommended treatment J under the prediction model is found as following. First, we choose all those treatments that provide a risk difference, a drop in relapse, that is at least as big as the threshold. And then among those treatments, we choose the one that has the maximum difference between the threshold and the risk difference, the effect size. So if none of the treatments exceeds the threshold, none of the treatment effects exceeds the threshold, then the control treatment is recommended for that patient. And let's see an example where the thresholds for dimethyl fumarate and glatiramer acetate are 90%, and for natalizumab is 35%. So because these drugs are older, but not without side effects at all, and actually one of them you need to get an injection in the hospital, it's not that the threshold is 0, they need, let's say the patients need to see at least a benefit of 19% before taking it, and 35% for natalizumab. So, and these are the results from our model. These are the thresholds we set, and assume a patient is somewhere here. Their baseline risk is somewhere around 35. So the risk difference compared to placebo for dimethyl fumarate is 23%. It's larger than the threshold, so it is an option. Dimethyl fumarate is an option for that patient, but glatiramer acetate is not. Natalizumab is also an option because the benefit exceeds the threshold, but the smallest, the largest difference between the benefit and the threshold is in dimethyl fumarate. So the model for that patient recommends the dimethyl fumarate. And now this is the formula we came up with for estimating the net benefit for many alternative treatment strategies. So the first bit, epsilon null minus epsilon s, S defines the strategy, is the reduction in a harmful event rate. So that's the difference between the probability to relapse under placebo minus the probability to relapse under strategy S treatment recommendation. And from that, we subtract the total number of patients that are under treatment J as recommended by strategy S, and that's multiplied by the threshold. And yeah. And remember, strategies could be any of these 5 options: treat everybody with one of the 3 active drugs, treat nobody, or treat according to the model. So how do we estimate these quantities? First of all, let's look at the proportion of patients treated with treatment J as recommended under strategy S. We need to first to find the congruent data set for strategy S, which I note as data S. And the congruent data set is a subset of the original data that includes those patients where the recommended treatment under strategy S matches exactly the actual given treatment. So we find these subsets, the congruent data set for strategy S, and from that data set, we can estimate the probability to take, or the proportion of people taking treatment J under this S strategy. And we, to estimate that, we did a meta-analysis of the proportion of people under each treatment J. Epsilon S is the event rate under strategy S. We first need to estimate the pool placebo event rate, and then we estimate the network meta-analysis risk ratio of each treatment versus the control, so placebo in that case, from the congruent data set. So again, we use the congruent data set under treatment and under strategy S to get the risk ratio, and then we estimate the treatment-specific event rate epsilon S under treatment J as the event rate under the control, the placebo here, multiplied by the risk ratio estimated from network meta-analysis in the congruent data set. And that I didn't explain because it's the event rate under placebo, so we can estimate it from the original data. So here are the 5 strategies, and for those particular thresholds, so the same 19% threshold for dimethyl fumarate and glatiramer acetate and 28% here for natalizumab, we get these net benefits. And if I multiply them by 100, we can interpret them as follows, that the strategy treats according to the prediction model leads to 5 fewer patients that will relapse per 100 participants compared to treat nobody, and 2 fewer participants compared to the strategy treat everyone with dimethyl fumarate. So by subtracting 0.03 by 0.05 multiplied by 100. So if we vary the threshold value for natalizumab between 20% and 40%, while we keep fixed at 19% the other 2 thresholds, you see how the net benefit changes for different threshold values, and up to a particular threshold value around 28%, 27%, the treatment based on the model is associated with the highest net benefit, but then we can treat everyone with dimethyl fumarate. How these things are interpreted is as follows. Our model is not superior along the entire range of thresholds. And that means that we cannot claim that if we apply the model to make decisions in clinical practice, these decisions would be better than applying, for example, giving to everybody dimethyl fumarate. And this is because we really don't know where the threshold values are. You usually do a sensitivity analysis and you look at range of reasonable threshold values. So it wouldn't be reasonable, say, to assume that one would take natalizumab less than 10%, or that will require 50% drop in relapse rate before taking natalizumab. So given that our model is not superior for the entire range of reasonable threshold values, then we cannot really advocate the adoption of the model in clinical practice. And this is a 2-dimensional version of that graph, where on the horizontal axis are reasonable thresholds for natalizumab, and on the vertical, reasonable, we think, thresholds for dimethyl fumarate and glatiramer acetate. And the colors show which strategy is preferable for each combination of thresholds. The red is our model, and you see for many threshold combinations, our model is preferable. And the numbers in the cells, they are the advantage in terms of net benefit per 100 participants of treating based on our model versus the second best strategy. So you see there are some thresholds, particularly for low threshold values for dimethyl fumarate and glatiramer acetate, that the model gives a substantial advantage compared to the second best option. for several threshold combinations, dimethyl fumarate, as we saw also before, is also a good alternative. And the values here, they show how much better is the strategy treat all with dimethyl fumarate compared to the strategy treat based on the model. And you see that the advantage is quite small. It's maximum 2 patients per 100 participants. So my conclusion from that is similar to what I told you before, that maybe the model needs to improve before we advocate further application in clinical practice and further considerations. And you can find some more details about that in an archive submitted paper. And just I will conclude with some limitations and take-home messages. We extended the risk modeling approach that has been previously applied in randomized trials into a network meta-regression setting. We combined the impact of covariates into a single predictor, the risk score, and then we feed an IPD network meta-regression with a simple predictor. The model is unfortunately time-consuming altogether because of these two stages. And we also extended the DCA methodology into a network meta-analysis setting to evaluate whether the model or which strategy in general leads to better clinical decisions. And the range of thresholds that we put, we did that after talking to some clinicians, but in practice, patient surveys are needed to identify the range of threshold values for which the patients will find interesting. And the results of such an exercise like DCA depend a lot on which range of thresholds are realistic. There are some estimation problems with decision curve analysis, particularly when we don't have a lot of data, as in our case, we had only 3 RCTs and up to 3,000 patients. Some of the congruent data sets were really small and didn't have all the drugs in all the 3 drugs there, and then we had to do some single arm synthesis instead of proper meta-analysis to estimate the expected number of events under a strategy. And I think that's the end of my presentation, and thank you for your patience, and I'm happy to take questions.